ไปกันต่อในเซสชันที่10ค่ะโดยในช่วงนี้ทุกท่านจะได้รับฟังการบรรยายในหัวข้อ GCxGC-TOFMS4D Method for Metabolite Profiling in Late Stage Diabetic Nephropathy Patient ของบริษัท Legal Instrument ประเทศไทยจำกัดโดยวันนี้ค่ะเราได้รับเกียรติจากคุณ Esha Dhakal QC Officer at United Pharmaceuticals ให้เกียรติเป็นวิทยากรบรรยายในวันนี้ค่ะเชิญรับชมค่ะ
สวัสดีค่ะทางบริษัท Legal Instrument นะคะวันนี้เราก็จะมาพูดถึงเกี่ยวกับตัวเครื่อง GCgC-TOFMS นะคะครั้งนี้เราได้รับเกียรติจากคุณอิชาดาเกานะคะจะมาพูดเกี่ยวกับตัว GCgC-TOFMS ซึ่งเป็นเครื่องแก๊สโครมาโตกราฟีที่มี4มิติค่ะก็คือใช้คอลัมน์2อันที่มีเฟสแตกต่างกันในการช่วยให้เราได้สารองค์ประกอบที่หลากหลายขึ้นในตัวอย่างการหลั่นเพียงแค่ครั้งเดียวค่ะเดี๋ยวจะให้คุณอิชาดาเกาเป็นคนพูดในเกี่ยวกับตัว GCgC-TOFMS แล้วก็การใช้งานด้านเมตาโบไลต์นะคะ Isha please start the presentation.
Okay. Good afternoon, everyone. So my name is Esha Dhakal, and the presentation for today, my topic is metabolite profiling for biomarker discovery in late-stage DME-SRD patient using GCgC-TOFMS. Okay, so basically to start my presentation, I just want to go through the outline that I have for today. So first, I will start with the introduction. Then I will talk about the research question. I'll talk about the objectives. Then I will go into result and discussion, and then give a conclusion about my studies. So to start, basically, DME-SRD or diabetic mellitus end-stage renal kidney disease is a kind of chronic kidney disease. So what happens is, in a chronic kidney disease, what we have is there is a gradual loss of kidney function over a period of time. And if you look at the prevalence of this disease around the world, you'll see that 10% of the population worldwide is affected by this disease, and it is one of the major cause of death and disability worldwide. CKD, it has different types, and one of the type is basically diabetic nephropathy, and the late stage of diabetic nephropathy, we call that DME-SRD. So if you look into the pathophysiology of DME-SRD, you will see that there is a lot of different factors which can be included as risk. So there is genetics, there is gender, there is duration of diabetes a person has, and also age, which can basically determine the person's chances of getting DME-SRD. And when you look at the pathophysiology, you will see that in a glomerulus of a person who has diabetic mellitus ESRD, you will see there is a diabetic glomerular region. There is a pathological quantities of urine albumin excretion, and also the ability to filtrate is reduced in diabetic patients. So the classical methods that is prevalent to diagnose DME-SRD is basically there are 4 different methods that are used. You use kidney biopsy, we use glomerular filtration rate, we use UACR, which basically stands for urine albumin to creatinine ratio, and urinary protein to creatinine ratio. And out of that, the main 2 which we have highlighted in red are the main ways that is basically used. We use UACR and eGFR or estimated glomerular filtration rate together to identify if a person has DME-SRD. Okay, so there are different stages of a person to classify which stage a person belongs to. So if you have a GFR that is greater than 90, then you will see your kidney damage is very less, or it is normal. And if you have the GFR that is less than 15, then you can say you are in the on the a very high spectrum of having this disease. So you can have a chance of kidney failure. And when you look into eGFR, the main thing that you really look into is you look into the serum creatinine. So basically, this is the breakdown of a product called creatinine phosphate in your body, and this creatinine phosphate is produced in your muscle, and this is broken down a lot in your body, and this is excreted through your urinary system. And what happens is, whenever you're looking into serum creatinine as an indicator, the main drawback of having this is basically the creatinine level. It will vary due to muscle mass. It will vary according to your gender and according to your age. So that is why EGFR might not be a very suitable method to look into what for the diagnosis of the patient with DM-ESRD. Okay, next. Okay. And then the other factor that they look into is they also look into UACR, which basically stands for urine albumin to creatinine ratio. So basically what happens is if a person has ESRD, they also have increased excretion of urinary albumin. So, and you take a ratio between the albumin that is excreted to creatinine that is excreted, and the result is interpreted as shown here in the picture. If you have greater than 300 UACR, then you have albuminuria or clinical proteinuria, which is basically you have like high chances of having ESRD. So these two factors, both UACR and EGFR together, are used to diagnose a person to have ESRD. Can you go? Okay, so as you can see here, you see EGFR and UACR we use that in combination to diagnose a person if he or she has DM-ESRD. Can you go to next slide? Okay, so what we are trying to do is we are trying to look into alternative to see that if there is another way in which we can look into different metabolites and say that if this person has DM-ESRD or not. So one of the way what we are trying to look is we are trying to tap into the field of metabolomics. So basically metabolomics, what does it stand for? It stands for comprehensive analysis of metabolites in any kind of biological specimen, and molecules that is studied in metabolomics varies. So it can either be sugar, it can be lipid, it can be fat molecules, right? It can be different kind of phenolic compounds, sugar, alcohol, this kind of small metabolites that we are trying to study in the field of metabolomics. And if you look at the sensitivity of metabolomics, what you will see is it is very high. So basically it can provide you better understanding of a phenotype that a person has. So that is why metabolomics is like a new emerging field in the field of clinical diagnostic. And there are several methods that you can use to for the identification of metabolites or in the field of metabolomics. So basically, if you look, we basically have used GCMS, and if you look into the sensitivity of GCMS, you see the sensitivity is higher compared to the NMR, right? So we could identify more metabolites more accurately. And also, if you look at the wide range of metabolites which we can identify through GC, it also had a wide range of metabolites that we can identify. That is why we kind of have chosen GCMS in this study. So the instrument that we are using is basically GCGC mass spec, in which is a bit different than GCMS. In this, what we have is instead of one column, we kind of have two columns through which the metabolites has to pass through. And these two columns, they are connected through a modulator. So what happens is the effluent which comes out through the first column goes into is trapped by a modulator, and then it goes into the second column. So basically what happens is there is two levels of separation that is happening between the metabolites. So as you can see, when you compare the graph, this is the first picture that you see is from the normal GC, whereas the second one you see is from the GCGC. So you see there is like two dimensions in which the separation is happening on the x-axis and also in the y-axis. So this is basically to show what is happening. So what happens is the first elute that comes out of the first column, that comes out of the first column will basically go through a modulator, then go onto the second column. And during that, what happens is the metabolites are separated more better. So that is why the end result that you get here is basically a separation on the first dimension and second dimension. And if any two metabolites, they have like same, they cannot be separated in the first dimension, like as we can see in the picture, they can be separated in the second dimension. So that is the basic advantage of using GCGC-TOFMS. So basically, when you are looking at the two level of separation that we were talking about, what we have is on the x-axis, the separation is basically due to boiling point, and on the y-axis, it is due to the polarity of the molecule. And we can also see it in the 3D, as we can see here. You can observe the different peaks to see like how much the metabolites has eluted. Okay, so the main purpose of using this study in DMESRD is basically the previous studies that we looked into. It showed like different metabolites were kind of being altered in the patient who had DMESRD. Like we see aspartic acid, arginine, which is basically a group of amino acid. We see arachidonic acid, which is basically a fatty acid, and different kind of group like sugar molecules were also altered in this DMESRD patient. So basically in this study, we try to focus into three groups. We focused on amino group, we focused on fatty acid group, we focused on sugar and sugar alcohol to see like what is the profile of these metabolites in a patient who has DMESRD compared to the patient who does not have DMESRD. Yes. So basically, to summarize, the problem that we were seeing again was that serum creatinine and UACR, they might not be effective because we said that serum creatinine basically varies according to your muscle mass, according to your gender and age. And also sometimes there can be EGFR loss without having albuminuria. So that might be some kind of like weird cases that we can have. So the best way basically to identify if a patient has DMESRD is by a biopsy, but then that is invasive. So like that is not commonly practiced unless it is like usually necessary. So we are trying to look for different other potential indicators to better study the disease. So our research question in this study was basically to see if we can use metabolomics approach to like improve the diagnostic method of DMESRD. And the conceptual framework is we try to combine both standard protocol and metabolomics approach, and hopefully this will improve the diagnosis of ESRD in diabetic patients. So we had like three objectives. The first objective was to create a method and to validate a method. The second objective was basically to apply the method that we have developed into profiling. And the third one is to try to improve the sensitivity of the protocol. So let's go into results and we'll see what did we do in all of these three to fulfill these objectives. Okay, the experimental design, that was basically we conducted biological experiment. We try to pick out the peaks, then we try to identify the metabolites, we try to see the significant features, and then we try to do the data analysis of the results. So let's go and let's look into results. The first and foremost thing that we did to like validate the method was basically we try to create an in-house library for different kind of sugar, different kind of amino acid, free fatty acids, and also polyol compounds. So when we ran these different metabolites, the results that we got are shown in the next slide. Can you go to the next? Okay. So can you go to the next slide? Sorry. So basically what did we see is, we saw that polyols, sugar alcohol, and amino acid and free fatty acids, which we could like run through the method that we had developed, and we see that most of them could be detected. And we use different level of metabolite detection and identification. Okay, and basically what did we found is like when you compare between normal and ESRD patients, we could see that the metabolites were like different. The profile of metabolites were different in the DMESRD group versus the normal group. There were some metabolites, especially sugar alcohol, or polyols, which were like higher in a patient who had DMESRD compared to the normal patients. So basically, the method that we have been optimized can be used to like profile metabolites in both plasma and serum samples. And we also found that whenever you are profiling these metabolites, we saw that polyols were like higher in a patient who had DME SRD, and also these polios could be a candidate biomarker which can be associated with the disease. Okay, and thank you so much for the presentation. Thank you so much for listening. Thank you.
Thank you so much, Isha. So, thank you so much, Isha, for the great presentation. สำหรับคนที่สนใจนะคะหรืออยากรู้ข้อมูลเพิ่มเติมเกี่ยวกับงานวิจัยตัวนี้แล้วก็ตัวผลิตภัณฑ์ก็คือเครื่อง GCxGC-TOFMS นะคะสามารถเข้ารับชมได้ที่ www.ligo.co.th ค่ะแล้วก็สำหรับถ้าสนใจในตัว Product เพิ่มเติมก็สามารถติดต่อเข้ามาที่ ligo อีเมลของ ligo ได้เลยค่ะก็คือ ligothailand@ligo.co.th ค่ะวันนี้ก็ทางบริษัท Ligo Instrument ก็ขอบคุณมากนะคะสวัสดีค่ะ
ขอขอบคุณคุณอิชาดากาล QC Officer at United Pharmaceuticals และบริษัท Ligo Instrument ประเทศไทยจำกัดค่ะที่ได้ให้เกียรตินะคะบรรยายในหัวข้อเกี่ยวกับเทคโนโลยี Gas Chromatography แบบ 4 มิติค่ะที่ทำงานร่วมกับระบบโมดูเลเตอร์นะคะค้นหาสสารเชิงปริมาณค่ะซึ่งจะทำการในการทำ metabolite profile นะคะในผู้ป่วยโรคไตเบาหวานจากการเป็นเบาหวานในระยะสุดท้ายนั่นเองค่ะถือว่าเป็นนวัตกรรมนะคะที่มีความน่าสนใจแล้วก็เป็นประโยชน์ต่อวงการการแพทย์เป็นอย่างยิ่งค่ะ